Our next talk is going to be by Dr. Sally Boyd, who's a resident at the Virginia Commonwealth University and Central Virginia VA healthcare system. She's going to be speaking about risk analysis index. When is the patient too frail to undergo a carotid and artery endarterectomy?
Hello, my name is Sally Boyd. I'm a general surgery resident at the Virginia Commonwealth University Health System in Richmond, Virginia. Today I'm going to be giving our talk entitled The Risk Analysis Index. When is the patient too frail to undergo a carotid endarterectomy? We have no disclosures, and the contents of this presentation do not represent the views of the United States Department of Veteran Affairs nor the United States government. Frailty is one patient factor that's distinct from age and comorbidities that's garnering attention in the surgical literature. It can be measured in a variety of ways and has been associated with poor postoperative outcomes in many different specialties, including vascular surgery and specifically patients undergoing carotid endarterectomy. The Risk Analysis Index, or RAI, is one validated measure of frailty that's been used to predict postoperative outcomes in many different types of surgical patients. It's based on the patient's history and factors in things such as age, cancer status, nutritional status, and certain comorbidities. It can be easily applied with retrospective chart review or calculated preoperatively without the use of patient testing or special equipment. The RAI was initially developed by Hall and colleagues and subsequently recalibrated by Aria and colleagues. The variables included in their respective scores are shown here on the right. As you can see, some variables have different assigned scores based on whether or not the patient has cancer and then whether or not the patient has cognitive decline. The Veteran Affairs Surgical Quality Improvement Program, or VASQIP, is a national database that houses information about patients who undergo operations in the VA health system. It uses CPT codes and has information about 30-day outcomes, including morbidity, mortality, length of stay, readmission, and reoperation. The objective of our study is to evaluate the effect of frailty as measured by the RAI on postoperative outcomes following CEA. For our methods, we use the VASQIP database to look at patients who underwent CEA between the years 2002 and 2015. We included asymptomatic patients only. We used chi-square, ANOVA, and binary logistic regressions in our statistical analysis. Based on previous studies using the RAI, we classified patients as non-frail if their score was less than 30, frail if their score fell between 30 and 34, and very frail if their score was greater than or equal to 35. For our results, over 40,000 asymptomatic patients underwent CEA. Over 98% of them were male, and the average age was 68 years old. 83% of patients were considered non-frail, 12.2% were considered frail, and only 4.7% were considered very frail. Frailty, as calculated by the RAI, was associated with increased rates of postoperative stroke, complications, death, and a longer hospital length of stay. In looking at our binary logistic regressions using the non-frail group as the reference group, we again found that increasing frailty was associated with higher risk of postoperative stroke and complications, including both frail and very frail groups. Only the very frail group was associated with death significantly. The limitations of our study include that the patient population was largely male. We were only able to examine 30-day outcomes versus more long-term outcomes, and details about complications are limited when using a large database such as the VASQIP. In conclusion, increasing frailty as determined by the RAI was associated with worse postoperative outcomes in asymptomatic patients undergoing CEA. Higher RAI cohorts had higher rates of post-op stroke, death, and complications. This data is congruent with other studies that have shown frailty to be associated with poor postoperative outcomes in vascular surgery patients. This highlights the importance of preoperative screening, risk stratification, and appropriate patient counseling. The Risk Analysis Index may be a useful tool in these discussions. This is my contact information, and I would like to thank VESS for the opportunity to present this project. Thank you.
Thank you, Dr. Boyd. This paper is open for discussion. I'll start off with a question. So the stroke rate in the very frail patients, if I'm remembering your slide correctly, was about 2.3%, which seems high for asymptomatic CEA. Any explanation for this?
The patients who are in the very frail group obviously have more comorbidities. They're tend to be older and those sorts of things. That would be my explanation for it. Again, we don't know the degree of stenosis in any of these patients. Unfortunately, we only know whether or not they have, if they're symptomatic or not. But I think that just given the fact that they're older, they have more likely to have congestive heart failure and things like that. So just the medical comorbidities.
Yeah, I would think that adjusting for the degree of stenosis is, an important factor, and I realize a limitation of administrative data sets, but I'm probably hindering you a little bit here. A question from Dr. Stern in the chat. Should we be offering CEA to frail asymptomatic patients or not?
So that's kind of the gray area. So the RAI has been, the different cutoffs have been kind of different in the literature. So some people use 10 as a cutoff, some people use 30, frail versus not frail, and then we use the 30 to 34 to kind of categorize that middle group there. I think for those groups, the people that are in the frail category, the decision to offer a CEA obviously needs to involve both the patient's family, but I think those are the patients that you might want to look more at the plaque morphology. You may want to look at transcranial Dopplers on these patients to see how vulnerable is this plaque, how likely is it to cause them problems later on, and then what's their life expectancy. This is where kind of that eyeball test that we do in the clinic can be helpful. Just do we think this person is going to benefit from the surgery based on how long we think they're going to live? So when they're in that middle category of the frail group, you might want to be using your adjunct sort of things like that eyeball test and then measuring their comorbidities and things.
And I take it you would be recommending that the very frail patients not be offered CEA in an asymptomatic setting.
Yeah, again, I think obviously it's a case-by-case basis, but typically the patients who are very frail are very unlikely to reap the benefits of having a carotid endarterectomy, and they're actually more likely, obviously, to have, the post-op stroke. Post-op MI was another thing that I did not include in the table for this presentation, but post-op MI was also significantly higher in that group, and then death. So it would seem like you would obviously go by case, but for those patients, I would be unlikely to offer them carotid surgery.
Question from Jeannie Ruddy. Very nice study and presentation. Any ideas on how to quickly or effectively integrate the system into the preoperative clinic?
Sure. So the risk analysis index, actually, there's two separate tools. The one that we use is called the RAI-A, and it can be used postoperatively when you kind of go back and do chart review on patients, which lends itself well to looking in the VAS clip and things like that. But there is also the RAI-C, which is a separate tool. They're kind of very similar, but it's a questionnaire that you give to patients. And those sorts of things, that study or that tool actually looks at the ADLs for the patient, which you don't really get that in the VAS clip as well. It's very similar to the other national databases in that it's just sort of, is the patient independent or dependent? Whereas the RAI-C will actually kind of break down the ADLs and what a patient is able to do, so it's a better measure of those functional status. I think the next sort of step in a project like this would be to use that RAI-C preoperatively in the clinic to see which patients kind of fall into the very frail or frail categories, and then use that in decision making.
How long does it take to collect data for the RAI-C? Is it something that we can reasonably incorporate into clinical practice?
Yes, so that's one of the advantages, I think, of the RAI is that there are tons of things that can measure frailty, but the RAI-C is a pretty short questionnaire that you give to patients. It's only, I think, a page or a page and a half long that they can kind of fill out, and then you calculate a score based on what they fill out. A lot of other tests require equipment or special time to do, like the time to get up and go test. It seems very simple, but it does require time in the clinic. It requires space in the clinic, which I'm not sure about other people's clinics, but with COVID, we're obviously trying to keep our social distancing and things. So it doesn't require any of that. It's just something you can give to the patient while they're waiting for you, and then you can calculate it very easily.
And question from Matt Corey. Did you evaluate incidence of delirium and correlations with RAI?
So that's not something we specifically looked at. The RAI does factor in what they call cognitive decline, which is any patient who's had sort of delirium, if they have any neurologic deficits or impaired sensorium at all, that is kind of included in the RAI. So that's definitely a component, but we didn't look at that specifically.
And how did you define asymptomatic in this cohort? Just never having a symptom, or not in the last 6 months, or what was the definition there?
So the way that we broke down symptomatic versus asymptomatic was by the ICD-9 and ICD-10 codes, with or without infarction piece.
All right, well, very well presented and nice work. Thank you very much.